So first I really call upon Dr. Gigi Augustine Madam. She's the Assistant Professor at Amala Institute of Medical Science. She'll be dealing with low-dose atropine. Thank you, ma'am.
Good afternoon, everyone. First of all, let me thank KSOS and Dr. Tanushree for giving me an opportunity to present this topic on low-dose atropine in controlling the myopia progression. So, what we know so far, we have enough scientific evidence, multiple clinical trials showed positive outcomes. Now it is an accepted treatment for the myopia progression. And 53% of the eye care practitioners prefer LDA as the first line management. So coming to the RCTs, the ATOM studies. In ATOM 1, they tried 1% atropine and showed that it is effective in controlling the myopia progression, but had unacceptable side effects like mydriasis and cycloplegia. And in ATOM 2, they compared the efficacy of 3 lower doses, that is 0.5, 0.1 and 0.01% atropine, and it was found that 0.01 was as effective as 0.1% and had least side effects. Greater rebound progression was noticed after stopping higher concentrations. Then came the lower concentration atropine studies, that is the LAMP studies. In LAMP 1, they compared further lower concentration, that is 0.05, 0.025 and 0.01%. And it was found that all concentrations were effective without much side effects. And 0.05 was the most effective in controlling spherically equivalent progression and axial length elongation. And in LAMP 2, they compared in non-myopic children between 4 to 9 years to evaluate the efficacy of 0.05% versus 0.01% atropine in the prevention of future myopia occurrence. And it was found that 0.05% atropine resulted in significantly lower incidence of myopia and fast myopic shift compared to 0.01%. Recently, there was some conflicting results regarding the effectiveness of 0.01% in American children. That is, there were 2 studies showing conflicting results between no efficacy and good efficacy. That was in American children. But there are numerous Indian studies which most of them reported with favorable results. So coming to the mechanism of action. The exact mechanism is still not known. It acts via muscarinic receptors at the posterior segment by influencing the local pathway at retinal, choroidal and scleral level. So mainly 3 actions, that is release of dopamine, inhibition of scleroblast and increasing the choroidal thickening. All this finally inhibits axial length elongation. Whom to prescribe? That is myopia progression more than 0.5 diopter per year between 6 to 16 years of age, astigmatism less than 1.5 diopters. And where it does not work, pathological myopia, lasered ROP children and index myopia. So contraindications, there are only relative ones, that is Down syndrome, heart diseases, etc., severe heart diseases, etc. And side effects, these are only temporary minor side effects like temporary stinging, blurred vision, sensitivity to light, etc. So how to start LDA? First of all, you need to counsel for a long-term use of LDA to the parents and the child. Take certain baseline measurements, cycloplegic refraction, axial length and keratometry in addition to the routine tests are a must, and record this in every follow-up visits. Prescribe atropine 0.01% eye drops, 1 drop at night both eyes, and follow up every 6 monthly. Inquire about compliance each time, which is very important. So when to stop atropine treatment? So when there is no progression for 2 years, a treatment period of 2 to 3 years is acceptable, and even up to 5 years is found to be safe in different studies. After stopping the drug, close follow-up is required to document any rebound myopia progression, and tapering should be considered before stopping the drug. There could be non-responders, that is increase in myopia more than 0.5 diopter per year even with the treatment, and there are 10 to 20% of non-responders. In rapid progressive myopia, there will be increase in myopia more than 1 diopter per year even with the treatment. How to manage them? Increase the frequency to 2 times a day, or switch to higher concentrations of LDA or other treatment modalities, and even combination therapy with other modalities of treatment. Recently, ARM study that is 0.05% atropine for rapid progressive myopia by Dr. Rohit Saxena et al. Was recently published in 2025, showed 62% reduction in the progression and with no side effect, adverse effects, with 0.05% atropine. Now it is commercially available in India. And a concept of pre-myopia was introduced by IMI, the International Myopia Institute. These are children who are not myopic at the moment, but they have a sufficient likelihood of future development of myopia to merit preventive interventions. Who are these children? Like, they have a refractive status between less than plus 0.75 diopter and minus 0.5 diopter. They will have some quantifiable risk factors like baseline refraction, age, as Dr. Thanos told, and other risk factors like ethnicity. Asians are at higher risk, and a positive family history, that is if for parents and siblings, if one parent is myopic 2 times, and if both parents 3 times chance of developing myopia. And unhealthy visual environment, that is more of near work and less of outdoor activities. So managing pre-myopia is more important than controlling myopia progression, because we can save the child from becoming myopic and its complications. So treatment of pre-myopia, close follow-up every 6 months, environmental modifications, outdoor activities, outdoor activities for more than 2 hours per day, reduce near work, 20-20-20 rule, etc. And low dose atropine can be considered only in high risk cases. So to conclude, LDA is the most documented and accepted intervention for control of myopia progression, and also in delaying the onset of myopia in pre-myopes. It is relatively cheaper, easily available, and with almost no side effects. Both 0.01% and 0.05 are commercially available now. Tapering may be needed as rebound myopia progression can happen, especially after stopping the higher concentration of drug. 0.05% LDA alone or in combination with other interventions can be explored among non-responders and rapid responders. There are still few unaddressed questions, that is how long the treatment can be continued, what's the long-term efficacy and adverse effects of 0.05 versus 0.01% atropine, management of rebound progression, and how to taper before stopping, how to record the compliance. It's very difficult to record the compliance of the patient. And there is a national consensus guideline given in IJO 2023. Thank you.
Thank you.